Say thank you very much for everyone that's at this session and for inviting me to talk at this session. And I think that, Eric brought up a very good point, and, he's talked about his own experience, his family's experience, and probably everyone in this room has been touched by cancer in some way, whether or not you've experienced it personally or someone that you know and love has experienced it. And I myself, have really been pushed forward in terms of the cancer field because my grandmother died of breast cancer. I knew her for many years growing up. She was never without breast cancer. And she was one of the first women who was ever on a clinical trial for a drug called tamoxifen, which is actually used to treat breast cancer today. I'm a breast specialist. And, part of me, every time I write that prescription for a patient that has breast cancer, I think, I'm able to do that today because of what my grandmother did over 30 years ago. And I think that that's pretty amazing. And I've been charged today, and now I'm being paid, but I've been charged today with actually talking to you about, really about the science and what we're really starting to learn, particularly in the area of genetics, what the promise is, where we're at right now, and really what the reality is, because some of what you may hear, you may think, well, it's just pie in the sky. That's something maybe 20 years down the road. But some of these things are actually happening right now. And you asked a very good question about participation in trials. And we have an office of research, and we also have a website where you can go and see what trials are at the Cancer Institute of New Jersey. A lot of them are clinical trials, but we also have other kinds of trials, supportive care trials. We have a trial that I'll even talk about today, which is essentially a blood test. And so there's many ways to get involved. I hope that all of you here, will take the opportunity to see what is available and to be involved where you can. To see where, my sister. Okay, she knew I was talking to. Okay, so I just wanted to start out by saying that there's really a myth in medical school, the medical textbooks, and that is one size does not fit all, okay? And we're taught when we go through medical school that patients have X, Y, and Z symptoms. When we examine them, they'll have X, Y, and Z signs on the physical exam. We give them X, Y, and Z drugs. This is what happens. Okay, but we know, there's an art to practicing medicine. And the reason why it's an art is because patients don't read the books, and neither does their disease. And so this is where the science starts. Everything that I'm saying today, although I tend to focus on breast cancer, can apply to other cancers as well. Okay? But if you were to take a group of women and follow those women through the course of their lifetime, you'll see that there's a group of women who never go on to develop any breast cancer. However, there's another group of women, it's not drawn to scale, that this group of women will actually go on to develop breast cancer. And so we know that the women that are in this group already are different from those women that are in that group. If we take all of these women that have breast cancer and let's say that they have the same stage of disease, the exact same kind of breast cancer, all of the same characteristics, and we actually give those patients the exact same best medicine that we have, what happens? We see that there's going to be a group of women who have what we call a good response. Those women are going to be cured. They'll never have to deal with breast cancer again. There's another group of women, a smaller group of women, thankfully, who fall into this category. Despite the best medicine, they either have progression of their disease, so it continues to grow, despite getting the therapy, or after having an interval where they don't have to deal with the disease at all, find that the disease comes back, and that's called a recurrence. And this is a problematic group, not because the patients are a problem, it's the disease that's a problem. And, we struggle with how best to treat these women to give them a quality of life and quantity of life. This group up here, we have a tendency to forget about altogether. And it doesn't matter whether or not they have a good response or a poor response. These are women who fall into a category that they have such severe side effects associated with the treatment that we give them that we have to change the dose, we have to change the schedule of the dosing. Sometimes we even have to change the drug or even stop the treatment altogether. And that can be a problem because someone who's responding very well, who has serious side effects, if we have to stop their treatment, they may not get that benefit anymore. So every place that you see a group of women, there's arrows that are diverging. This group here, those arrows. There's something different about the individuals that fall into those different groups. And there's a growing number of investigators, including myself, who believe that genetics is really underlying some of those individual differences that we see. All right, we're going to go back to high school biology. Some of you in this room might have been part of the curriculum when you were in school. But let's start with the cell and really where the instruction for the function of a cell comes from, and that's the nucleus. So if this is the cell here, it's kind of like a bag. There's another bag that's inside, and that's called the nucleus. You'll see these structures that look kind of like clothespins. They're called chromosomes. You get one from mom, you get one from dad. There's a total of 46 of them altogether. So there's 2 pairs of 23. But what you'll notice is the chromosome is a tightly wound, almost like a ball of string, if you want to think of it that way. And as you unwind it, and you come down into this direction here, now you see that you have this kind of winding structure, kind of like a winding staircase. That's called the double helix. That's DNA. And then if you really unwind that DNA, you see there's a strand of DNA here, there's a strand of DNA here, and then you see, I'm having a hard time seeing it from this angle, but there are letters here, and then there's bonds between those letters, and those bonds actually hold together those 2 strands of DNA. So let's go back to DNA. There's actually 4 building blocks for DNA, and we represent them by those letters, A, G, C, and T. And what you can do is you can string together a bunch of letters to essentially form a word. Okay, and you can put these 4 letters in a bunch of different combinations to spell different words. Ultimately, when you take those words and you put the words together, you make a gene. Okay, so essentially you have a sentence. So genes are composed of DNA sequences that are grouped together. Those are really the functional units of inheritance. And there's at least 30,000 genes encoded on those chromosomes. So DNA is the smallest unit, okay? The words, genes are the sentences. And so a sentence tells the cell what it needs to do, okay? But DNA can't do what the cell needs to do. That function is carried out by proteins. So a gene dictates what proteins are made, and then those proteins actually carry out the function. So you can imagine if you change the DNA, you change the sentence for that gene, and ultimately you can affect the protein, and then you affect how a cell functions. So I have to say I didn't come up with this one myself. I stole this from one of my colleagues. Let's consider if your DNA was a book. A lot of you have probably read War and Peace. I admit it, I read the Cliff Notes in high school. This book is 920 pages long. If you, on average, there's 3,000 characters per page, and the total character count in this book is almost 3 million characters, okay? And so if you were to pretend that your DNA is this book, and your DNA actually in every cell there's 3 billion characters, you would have to read, to have the cell function, 1,100 of those books, okay? That's a lot of books. And so every time a cell makes a new cell, okay, you're essentially taking 1,100 of these books and transcribing them all over again, okay? And in that process, you can wind up with mistakes. Some of the mistakes don't really affect the cell. Some of the mistakes affect the cell, with a significant degree. And so you'll hear a little bit about some of these mistakes or changes and how they can affect function. So where we really learn the most in terms of some of these DNA changes and what they mean in populations. The first real big piece of evidence in terms of people having differences in their DNA comes from the Human Genome Project. In the mid to late 1990s, there was full sequencing of the human genome. And so they took an individual and found that sequence of letters throughout all the DNA in the cell. And what they found, if you look to the person that's sitting next to you, like it or not, you're 99.9% alike at the DNA level, even if you don't look anything alike. Okay? And so it's that 0.1% of DNA that's different. That's what makes you unique, but probably also has an effect in terms of what your susceptibility is in terms of developing certain diseases. And so that 0.1% of variation in the DNA, we call those polymorphisms. There are different kinds of polymorphisms that you can find, and I show several of them here. Okay, there's not going to be a test later, but to give you an example of the different kinds, where this one here, it's called a single nucleotide polymorphism, or SNP. It's essentially taking one letter in this 3-letter sequence, and you change one letter. That's the most common form of polymorphism between individuals. There's also deletion insertion polymorphisms. We call those DIPs. And here you can see that this sequence has an A at the second position, but then it gets deleted. Likewise, you can have the opposite scenario where you insert an A back into that position. Simple tandem repeats. I'm showing you this because you'll see a real example of this, how we use it in the clinic, where you have a T and an A next to one another, and those get repeated. But in some individuals, instead of having, I think that's 3 there, now you wind up with 5. Okay? And then we're finding out more, not just about single bases in the DNA that get changes, those single letter changes, but things that we call copy number variations or copy number polymorphisms, and essentially taking whole regions of DNA and having multiple copies of those or deletions of those. So if we go back to the book, War and Peace, and Leo Tolstoy, cannot take the credit for this sentence. This is my own literary attempt. The men were cold, wet, and hungry, as they look like on the cover there. Now, if you can imagine, if you have a deletion polymorphism where you get rid of the word wet, the sentence reads as this: the men were cold and hungry. Okay, I think you get the idea. It's kind of like you get the gist that the men were miserable, okay, but it doesn't read exactly the way that the original sentence was. You still understand the book, you still understand the chapter, nothing really changes. But let's say you just delete the letter M, so from men here, now you see that this sentence changes and you can't read it. If that perturbs the rest of the paragraph and the rest of the chapter, you'll miss a whole aspect of that storyline, and it may make the rest of the book incomprehensible. So why are polymorphisms important? Unlike mutations, which are rare in the population, these are found in more than 1% of the population, but can occur in up to a half of people in the population. So it can affect a lot more individuals than the unfortunate individuals who develop a mutation in genes that we know are important in cancer already. So just to remind you, polymorphisms are DNA changes that can change either the amount of a protein that's made, so the functional unit of a gene, or how a protein functions, and that can alter the function of a cell. So let me give you 2 examples. Again, single nucleotide polymorphism, or SNP. This is essentially changing a single letter in the DNA sequence. So if you look at 3 individuals here, and remember, you get a copy from mom and a copy from dad. So you see for each individual that there's 2 strands. In this individual, you see a T at the 7th position. What that gene does is it tells the protein that, and amino acids are the building blocks of proteins, that now you're going to have this amino acid, which is called the leucine, at that position. Individual number 3, however, instead of having a T at that position, has a G. What happens? now that protein, instead of having a leucine amino acid, now it has a valine. And individual number 2 got a copy of T from mom, for instance, a G from dad, and now you see that they have one of each amino acid. And the interesting thing is that changing that amino acid may have no change in the function of that protein, but it may change the function significantly enough if this were a protein that actually determined how you responded to chemotherapy. Changing that amino acid may mean the difference between you have a response or you have no response. These kinds of DNA changes or polymorphisms can also contribute to gene expression. So how much of the gene is there, or I should say protein is there. Genes have on-off regions, so areas that regulate whether or not the gene is being expressed. And if you have a variation in the DNA sequence that occurs in that on-off switch, that can affect how much of the protein is actually made. And what we know for breast cancer, for instance, and we're starting to find out in other tumor types, is that not every cancer is exactly the same. There's lots of different subgroups within breast cancer. It's not just one disease. And so depending on what type of breast cancer you're looking at, you can see different expression of different genes. And it's possible that some of these genetic variations that I'm telling you about can determine the type of breast cancer, for instance, that a person develops. I like this example. It has nothing to do with people per se. I'm a dog lover, and I saw this cover of Science. It's a prominent scientific research journal, and you can see that there's a Great Dane here, big dog, and then there's a Chihuahua. I'm partial to the small dogs myself. And so the question that came up is, how can you have two animals that have 99.9% of the same DNA, yet one is huge, probably taller than me, and then you have one that's really tiny? And so there are certain growth factors that help to determine how big we grow to be. And so the first thing that this particular group of researchers did was took blood samples from these dogs and said, are there certain growth factors that are at different levels in these dogs? And there was one particular growth factor. It's called IGF-1. And they found that it was at very high levels, to no surprise in large dog breeds, and in very low levels in small dog breeds. Okay? So now I just told you that changes in a DNA sequence in the on-off switch of a gene can mean you have more or less of that gene being expressed. Okay? IGF-1 is a protein. And so if you change the DNA sequence in that on-off switch, you change how much IGF-1 is made. And in fact, they found that there is a DNA sequence change that correlates with the level of that growth factor. And the difference in size in these dogs can really be related to that sequence change in that particular gene. The reason why I show this is it's a pretty dramatic example of what a single base change can do and the kind of effect that you can see. So now we can take this to people and start asking questions if there's correlations between changes in DNA in lots of different genes and whether or not someone develops a cancer. We're actually doing that at the Cancer Institute of New Jersey. It's called the Breast Cancer SNP trial. We have already over 1,600 patients enrolled, but as Dr. Praxis mentioned, these kinds of studies really need many individuals to participate. Most of the participants so far are patients that have breast cancer. We also enroll patients that have high risk for developing breast cancer, and also healthy volunteers. What kind of questions do we ask? These kinds of questions are also being done at other facilities. That includes Dr. Love's Army of Women, as you asked about. And so it doesn't matter what the gene is to you, but what I can tell you is that we had identified a DNA change in the on-off switch of this gene. And we hypothesize here that if you had a variation in that DNA sequence, that would change the age at which women develop breast cancer. And so we took women who were on the SNP trial. We took their blood, we isolated DNA from the blood, and we analyzed the DNA for the sequence in this gene. And we asked, how old were women when they were diagnosed? And you're going to see these kinds of graphs. Along the bottom is the age of diagnosis of breast cancer. You're going to see two lines. This red line here corresponds to individuals who have the normal sequence of DNA. Women who fall on this line are those women who carry the 2 copies of that sequence change. And if the curve is shifted to the left, that essentially tells you that those women, these women on the blue line here, are actually developing their breast cancer at an earlier age. And in this particular case, it was 8 years. We can look at other genes. Again, not important in terms of what gene this is, okay? And as a matter of fact, we don't know yet what this particular DNA change in this gene does. It's not in an on-off position necessarily. But if we look again at the age at which women develop breast cancer, if they're premenopausal when they develop their breast cancer, these two curves essentially are the same. But if we look at women who develop breast cancer after menopause, now we see that one of these curves is this time right shifted relative to the other one. So these are women who have the normal sequence of DNA. These women here have a sequence change. Now you can see that they have a later onset of breast cancer. So I almost think of it kind of like a protective effect. And so here what we can say is that the specific population of women that we're looking at is important, where it only has an effect seemingly in postmenopausal women as compared to premenopausal women. What I'm not going to show you, but I'm going to tell you, is that the differences between these two curves changes depending on how much a patient weighs when they're diagnosed, where those curves actually become further apart. And that brings me to this point. Gene and environment interactions are important. And you can't necessarily modify your genetic predisposition. It's there. But you can modify your environment. And when we talk about environment, we tend to think about external factors. So things like smoking, alcohol, maybe previous radiation or toxin exposures. But it also applies to internal environment, especially in breast cancer, talking about fluxes in hormones, metabolism, and as I just mentioned, obesity. And the reason why I bring this one up is because I think that lung cancer is probably a really good example of gene-environment interactions. Most everyone here, no matter who you ask, will say, what's the cause of lung cancer? Most of you will say smoking. And what we know, though, is that everyone who smokes, not everyone develops lung cancer. We also know that there's people who don't smoke, like Dana Reeve, for instance, develops lung cancer. And so, it's not necessarily one or the other, and there's probably a combination of these things that influence that person's susceptibility. So what I've shown you so far are some cartoons of data that involve looking at individuals who already have breast cancer. But it's important to recruit all kinds of individuals for these kinds of studies. And this is just a reminder that if you have this balance here between healthy individuals and women who develop breast cancer, that scale is not even. What you're really going to see is that there's unevenness in this balance, and it's probably due to, at least in part, underlying genetics. And so for these kinds of studies, we need individuals who have breast cancer, but we also need individuals who don't have breast cancer, and to start looking at differences between those individuals. So I wanted to shift gears a little bit and to talk about something that Eric touched upon, and that's prognosis. And polymorphisms or DNA changes can affect prognosis. And so if you take all women that have breast cancer, as I talked about before, and you give them all the same treatment, you're going to have these individuals who fall into the good treatment response category. But they're really not all one category. They're essentially more than one category, where you have some of these women, they needed to get their treatment in order to be cured. However, there's probably some women who are in this good treatment response category that they would have done well regardless of whether or not you gave them treatment. And that's really talking about the natural history or the natural biology of that particular cancer. It has nothing to do with what we did or we didn't do. And again, that's prognosis. And so again, the difference between this group and that group we think is related to genetics. And to give you an example, that's what's shown in this graph here. You see days here. Okay, so this is a time frame where time 0 is when a woman is diagnosed with breast cancer. We follow women for a number of years after they've been diagnosed with breast cancer, and we ask, who has a recurrence? When did they have that recurrence? And the 3 plots that you see here refer to, this is the 2 copies of the normal DNA sequence in this particular gene. This is a copy of the normal letter. This is the variation. And then the green line is for those women who carry 2 copies of the variation. What you can see, the red and the blue lines overlie one another. So if you have at least 1 good copy, you do okay. However, if you have 2 copies of that variation, now you see that that line really falls away from the other 2. That distance between the red and blue down to the green, that tells us that those individuals have more recurrences. The fact that if you travel back here and you see it starts stripping away, it's about 3 years. Those women are actually having recurrences very early. What I didn't tell you, this particular subset of breast cancer that we're looking at in this graph, these are women who we typically think of as doing very well overall. Yet this clearly shows us that not all women with that particular subtype that we would say would do well are actually doing well. And here, there's an association in terms of the underlying genetics. So it may be that these women here, we need to start thinking about treating them a little bit differently. Cancer is not caused by any single gene. I think I've been starting to allude to that. It's a complex disease. I've already told you about gene-environment effects. You can also have gene-gene effects, meaning that you can have a change in one gene, you have a change in another gene, and that's worse than having a change in one gene alone. And to demonstrate that, consider if you have 10 different genes, and just kind of giving them numbers here. And let's say we also know that hormone replacement therapy can be a risk factor for developing breast cancer. If you have only a change in gene 3 or only a change in gene 6 or neither of them but you take hormone replacement therapy, you may have the same risk of developing breast cancer. Whoops. But if you have changes in all 10 genes and you take hormone replacement therapy, that may put you at the highest risk of developing breast cancer. Likewise, you can have different combinations of which genes have variations in them, where this one, this combination, if you take hormone replacement therapy, is the same as this combination of variations without taking hormone replacement therapy. And there are examples in the literature that are starting to support this. So how can we use DNA testing of this sort to incorporate it into prevention or risk reduction of breast cancer? Essentially, the hope is to actually develop a blood test which is going to represent multiple genes and variations in those genes, and to use that test to identify which individuals are actually at the highest risk of developing breast cancer, but then who develops breast cancer at the earliest age, because then we can really start intervening how and when we need to intervene. So that means screening. Who should be getting screening in the first place? When do we begin? It may be that although mammograms are the best screening technique we have for breast cancer, maybe those women should be having MRI screening. We can also give chemo prevention, and we have effective agents for chemo prevention for breast cancer. And so we have the potential to intervene in that way. There are other types of interventions that we won't go into, and also prevention trials. So what I told you was a little bit about the promise. We're getting there. I don't think we're exactly there just yet. But now I want to give you examples that are clearly already here, the reality. And that's really in cancer treatment. And so to use the presence of DNA changes to predict response to therapy, that includes hormonal therapies, radiation, chemotherapy, targeted agents, biologic agents, how we can use that information to change dosing for each patient, and also to know who it's safe to give a particular treatment to. And that's really here, as I said, there are two aspects to this in terms of fields of study. One is pharmacogenetics, the other is pharmacogenomics. I won't go into this, but the goal is really the right drug for the right patient and the right dose for each patient. To understand a little bit about why a drug may be effective or not, part of that really has to do with how a drug gets metabolized in the body. And a lot of people don't know why your liver is so important and what happens when you damage your liver, but the liver is really responsible for taking drugs, taking just substances that are normally found in the body, taking food substances, for instance, as part of your digestion, converting those substances so that you can utilize, they're in a form you can actually utilize, or make them excretable from the body. And so the liver performs all those chemical reactions. There's at least 57 of these functional proteins or enzymes found in the liver, and that's kind of indicated by these pie graphs here. Just shows bigger classes of these enzymes. And it's really the levels of the enzymes that are there and how functional they are that determines the level of a drug. So I wanted to concentrate on one particular enzyme because I have two examples here for that are already in use. And that's an enzyme, it's called CYP2D6. And there are variations in the DNA in the CYP2D6 gene that have real clinical implications. And we know that this enzyme, the CYP2D6 enzyme, has 4 levels of activity. We call them ultra-rapid metabolizers, extensive metabolizers, intermediate metabolizers, and poor metabolizers. I think you might get the hint that these guys, the poor metabolizers, they may not be the best group to be. This is one reason. We have medicines that we give to patients to help in terms of pain relief, also as cough suppressant. Those include narcotics like codeine. And essentially codeine, when that's taken, doesn't stay that same way in the body. It actually gets converted by the CYP2D6 enzyme and becomes morphine. Most of you have probably heard about morphine. And so we know, though, that where you have DNA changes in the CYP2D6 gene, that can correlate with a markedly decreased activity of the protein, hence the poor metabolizer. And as high as a third of individuals can be poor metabolizers. So what happens if you give those individuals codeine? They never make morphine. They don't get pain relief. Codeine in and of itself has its own side effects. It may get broken down into other side products, and those side products have their side effects as well. So they don't get the benefit, but they certainly get the side effects. Here's another example of how the CYP2D6 DNA variations becomes important, and that's really in the use of tamoxifen. Tamoxifen is an agent that's very effective in treating breast cancer. Most breast cancers actually use estrogens as a growth signal, and tamoxifen is an anti-estrogen which blocks that growth signal. This is why it becomes effective. It's a pill. When you take it, it actually gets converted by that same CYP2D6 enzyme. And so tamoxifen is not active, it gets converted. Now you have an active form, it's called endoxifen. So if you fall into that poor metabolizer group, what happens? The drug remains as tamoxifen. You get very little endoxifen formed. And so you can imagine as a poor metabolizer, you're not getting a high enough or a therapeutic dose of the endoxifen. And so you won't have the best benefit of this medication. And there's also alternative medications that a clinician could then think about giving you as an alternative to tamoxifen. The genetic test was actually approved by the FDA in 2005. So this is where we really are here. Blood sample can actually be sent to a lab that performs this kind of analysis. It's called the AmpliChip P450, and really can allow clinicians to tailor the medication based on a genetic profile of an individual patient. And I hope that I've demonstrated for you with 2 examples that it really does have clinical utility. It just has for genetic changes in that gene. There's actually another gene which I didn't talk about. It's the CYP2C19, which is another drug metabolizing gene. That's right up here. So I want to give you another example. I talked about that group of patients who wind up with severe side effects, regardless of how they respond to treatment. And so it's okay if you're a responder and you don't have any toxicity when we give you treatment, but it's not okay if you fall in this group of non-responders or what we call toxic responders, so where you have such serious side effects that we need to change the drug or stop treating. And so an example where we can intervene in this particular way is with a drug called Irinotecan, or CPT-11. And although this is a drug that's primarily used to treat colon cancer, it's sort of re-emerging and being tried in terms of treating breast cancers that are resistant to hormonal manipulation. Okay? And although it can be an effective drug, in a certain proportion of patients, up to a third, you can have severe diarrhea or low white blood counts. And why is that important? Well, you might say, oh, you have diarrhea, give them Imodium. Okay, but this kind of diarrhea is not responsive to the kinds of drugs that we have to treat that symptom. And so patients wind up in the hospital because they're so severely dehydrated, or they have such severe imbalances in their electrolytes that it could be potentially fatal. Low white blood counts predisposes to infections very rapidly, and severe infections. And so even having 1 dose of this drug can be fatal for certain individuals. And we know that the drug levels are determined by how it gets metabolized in the body. And what metabolizes it is one of those liver enzymes called UGT1A1. Let me tell you why this is important. We actually know that there's a variation in the DNA in this particular gene. I'm calling it 66 here, or 77, and this is what it means. Normally, in the normal case, for instance, you have a string of 6 TAs in a row, and that's on 2 strands, so copy from mom, copy from dad. Those individuals will have activity against cancer. Okay, but if you have this case, 7-7, instead of having 6, you now have a string of 7 of those TAs, and on 2 copies. They have even better anti-cancer activity, but guess what? They're the ones that suffer the severe low white blood cell counts and the intractable diarrhea. And why does that happen? Irinotecan, when it's given, is inactive. It actually gets converted by an enzyme to the active form of the drug. That active form gives anti-cancer activity, but also gives the side effects. That active drug is converted again, and that conversion is performed by UGT1A1 into the inactive form of the drug, so it can be excreted from the body. So everyone here, probably from New Jersey, you know what the traffic is like. There's an accident, there's construction on the side of the road. So unlike these lanes, which are going around hunky-dory just fine, you can kind of imagine just going straight through there the way it should. Now you see this car on the side of the road, you only have 1 lane getting through. Okay? So you're not making, which would be down here, the inactive drug. Oops. So what happens is you get all these cars backed up here, essentially the active drug. So you do get the anti-cancer activity, but now you're getting way too much drug, and now you wind up with the side effects. Okay, so you really, individuals that have a block in this conversion here, they wind up with serious problems. If you look at a population of individuals, as in this particular study, they looked at a group of, for instance, 10 individuals. How many of them carried 2 copies of 6 compared to 2 copies of 7 and then 1 copy of each? You can see half of individuals, so 5 out of the 10, have the normal sequence. Only 1 out of 10 has the variation. But the important thing really lies in what we see in this column here. If you have 2 copies of 6, you have no risk of having that side effect, either side effect. If you have 1 copy of each, now your risk is 20%. However, if you're that individual, and if you're that individual, that's all that matters, you have a 50-50 chance of winding up with a severe reaction that could be potentially fatal. And so this is why it's important to start understanding why we need to think about differences between individuals. It's not equal depending on what ethnic groups you're looking at. Caucasian individuals, that's 7-7, which is the group that wind up with the side effects, about 11%. Asian individuals, 2%. African Americans are the highest, nearly 20%, so 1 in 5 can have that reaction. There's actually a FDA-approved test for this as well. It's called the Invader UGT1A1 molecular assay. And so we know if there's certain individuals that carry this 7-7 variation, that we need to adjust the dose of the drug for those individuals. There's some of you who are in this room who might actually fall into that category. If you've ever been told you have Gilbert's disease, or if you found to have fluctuating levels in terms of your serum bilirubin, that's part of your blood test, that may be you. And so that could be information that's important to you. Ultimately, what's driving growth in this molecular kind of testing? One thing that we know from experience is that, and Dr. Praxelis referred to Velcade, I think, in his talk, and that we think we develop these blockbuster drugs, and then when we go to test them, they're not effective like we thought they were going to be. And we have an example of a drug that really is a blockbuster drug for breast cancer, and that's called Herceptin. Only 21% of individuals have a molecular change that means that they'll be responsive to this drug. And if you were just to treat every woman that has breast cancer with this drug, you would say it's not an effective drug. But we can actually identify a genetic change or gene expression that says, here's the 21% of women, and that drug reduces their risk of recurrence in half. Okay, and that is really a significant benefit for those individuals. Things that we're learning from the Human Genome Project, are helping to propel other research forward using high-power computing, bioinformatics, other kinds of technologies. We're able to move forward. Just you all being here as a public, and you're demanding what you want. You want other clinical trials that are available and in your backyard. Okay? What is your predisposition? How can you change it? What can you do? How can you make your outcome better? And we're seeing even more in this regard, especially from certain populations. I want to say women are very vocal. This is why breast cancer really gets a lot of funding. But even now the African American population, because we know that those women develop much more aggressive forms of breast cancer and at much younger ages. Up to 40% of individuals may actually be receiving the wrong drug or the wrong dose. We can actually make an impact on that if we can predict who will have the best response to a particular drug. There's a high volume of adverse reactions, and if we can predict those individuals, we can save them the experience of having a lot of those side effects. In 1995, it was shown that adverse drug reactions for the sixth leading cause of death. And really, when you start looking at costs in the year 2000, that translates into $177 billion. And while genetics may not explain all of that, it can certainly explain some of that. And so this is actually my last slide. and this is alluding to personalized medicine. I know Eric also mentioned that. And really, this is talking about individualizing treatment based on your individual characteristics. And again, looking at it from the perspective of what information your DNA holds and how we can predict risk of disease, how we can look at prognosis, know what drugs to give, how they're metabolized, how we can prevent side effects in individuals. And really, the more research that we do to understand some of these changes and how combinations of those changes ultimately impact on all those features, we can really make an improvement in terms of what we can do clinically and help people not only survive longer, but to survive better. And so I told you a little bit about the promise, I told you a little bit about the reality, and we're certainly moving in that direction. And again, it's the right drug for the right patient and the right dose for each patient. And I think I'm going to end there, except to say I had to do my public service announcement. If you're of the age of 40 or older, you should be getting a mammogram yearly. See your physician every year for a breast exam and learn how to do your own breast exams. Become your own best expert. I have women that tell me in the clinic they don't like to get their mammograms because it's uncomfortable.